Hello and welcome to Everyday Oral Surgery. This is your host, Dr. Grant Stucki. I am an oral and maxillofacial surgeon practicing in Denver, Colorado. The goal of this podcast is to connect, learn, and inspire. In this podcast, you'll be hearing from OMS surgeons all over the globe discussing ways to improve the practice of oral and maxillofacial surgery. Most information shared in this podcast will be based on personal experience and opinions, so please supplement what you learn here with approved research studies. Without further ado, please enjoy today's episode. All right, welcome everyone back to another episode. Today I'm with Dr. Jacob Stucki. He's an oral maxillofacial surgeon practicing in Denver. This is Grant Stucki. Jake, good to be here with you. How you doing?
Doing great. Glad to be back.
Yes, awesome. Before we jump into our topic, we've been doing a lot of work on the website. Do you want to mention a little bit about that?
Yeah, absolutely. I made the website a couple of years ago, and when it first started getting announced, and realistically, it was pretty basic and not super functional. So now that I had a little bit more time, I went in, basically just redesigned the thing from the ground up. So it's a lot more helpful for the podcast. It's got links to all the different places where you can listen to the podcast. It's got all the show notes, and then most importantly, it also has the blog, which it's cool. Dr. Stucki's been doing some blog posts periodically with like a deeper dive into some of the topics that aren't actually on the podcast, and then the forum is really, really cool. So for anybody who's listening, definitely encourage you to go on the website, make an account. We're trying to keep it to be verified users. It's not anonymous. It's everyone can just share what they're thinking, try to be really positive, kind of collaborative place. So you'll ask for your name, where you went to school, and then if you're a resident or if you're a surgeon, where you went to residency, and then we'll approve you, and you can hop on the forum. And what's cool about the forum is it's got every single podcast, all the show notes, tags, super easily searchable if you want to find anything that's ever been discussed in the podcast. And then it's got just a ton of different areas where you can, discuss questions, cases, post different questions or pictures or whatever it is, and just have discussion with people on there. So we're trying to add more study material, add material about different residencies, and just make it a place where you can discuss and learn about oral surgery in a little more organized fashion.
Yeah, for sure. I would just add, so we've done, over 375, almost 400 episodes, and it's just hard, to search those online. And what's really cool is, like you're mentioning, we made them searchable through many means. You can type in the name of like surgeon you remember you heard. You could look by a topic, say, oh, let's see all of the podcasts that are talking about implants or trauma or ACLS type stuff. So it's a great way to do it because it's just difficult to search when you have so many episodes. So that alone is worth getting on the website to check it out. And then we really encourage our listeners to get on there and reply to both the podcasts things and kind of say, just a little blurb of what you thought about the podcast, good or bad. I mean, we're always open to, either ideas. If you're like, oh yeah, they should have mentioned this perspective or that thing, we'd love to hear it. And then also, like Jake's saying, the forums and podcasts or blog posts, it's invaluable to have our listeners commenting on there. And so I think it's just a really good resource. So thanks for all you've done, Jake. It's incredible work.
Yeah, absolutely.
Awesome. So today we want to talk a little bit about kind of the process of like atraumatic extraction in preparation for an implant, either immediate or delayed implant. Where would you start us off on a topic like this?
Yeah, so I think when it comes to implants, one of the big things that leads us to have difficult outcomes or complications with implants, if you were to back it all the way up to the extraction, it starts there, right? So many of the implant complications we see start with what's going on at the time of extraction. So, many of the outcomes and whether immediate implants or delayed implants, they often happen or they're kind of heavily influenced before you even begin placing that implant. So I think that's the idea I just want us to think about, which is what can we do at the time of extraction to really optimize and prepare that area to have an implant in the future and just have the most success. So, I guess that begs the question, what's the goal of the extraction? Is it To remove the tooth? Well, yes, but that's not the only goal. There's a lot of ways to remove the tooth. I was told, as an intern, no tooth can withstand being extracted if you remove enough bone, right? And like that's totally true, right? You can take a handpiece, you can take a ronger, and you can remove every morsel of bone attached to that tooth, and it will fall out, right? But the question is if we can find ways to extract the tooth while preserving as much bone as possible and doing it proficiently, not taking forever, doing it quick and painlessly, then we can set ourselves up for success.
Yeah. I love that concept. That concept that especially immediate implants, but even delayed implants are I liken it to real estate almost. You know how like the real battle of real estate is won and the purchase price at the very beginning is the deal you get. That's like similar to this process, right? It's like the least amount of bone, the more bone you leave, like um the more atraumatic it is just setting everything up for greater success. So great concept.
Yeah, and I think, sometimes when we hear, atraumatic extraction, we just think like, oh, you just have to be really slow. You can't use a drill. You can't do what the oral surgeons do. And it's like that's not true at all, right? The techniques that we know and that we use all have a place. And so I think kind of just learning a little bit more about how to use different techniques makes a big difference. So recently I've been placing many, many, many implants, many immediate implants in particular, and so that's kind of one of the things that prompted me to talk to you about this. And we've been talking about it recently. Just how do we optimize this? So, as most of our listeners know, when it comes to placing an implant, one of the most important aspects of that, you for sure need enough bone. You need vertical height, you need horizontal height, you need to avoid any vital structures, the nerve, the sinus, other things that can be in the area, other roots. But one of the biggest things is that buccal plate. As we know, when you take out a tooth, a lot of times you think, we're doing a buccal trough. If you can't get out the roots, if you're taking out a wisdom tooth, you think when you're placing an implant, you hear you want at least 2 millimeters of distance between that buccal plate and the implant. And sometimes if that buccal plate's really low, you're gonna need to sink the implant in deep. So you start thinking about all these different things about how the bone influences where you're gonna place that implant, right? The lower that buccal bone is, the lower the implant, how's that gonna affect the crown? It's like this cascade of things that happen when that site starts getting a bit compromised. So when you let's say you're doing an immediate implant and you start working on taking out a tooth, kind of what's your typical approach?
When you're taking out a tooth, so I mean, usually I'm doing like a circular incision, doing a minimal flap reflection, because I'm trying to think, hey, if I can leave enough soft tissue, especially on the buccal, it's going to be less bone resorption. And then it's just elevating, right, atraumatically and trying to get that tooth. I do a ton of work with my elevator before I even touch the tooth with the forceps. What other tips do you have for the beginning part of the extraction?
Yeah, I mean just the basic stuff. Many times you do that, small flap, elevate, grab the proper forcep, do a little rotation, buccal lingual, carefully, comes right out. And you're done. That was an atraumatic extraction. That's like best case scenario. I think one thing you want to, I'm sure many people have seen is where you're doing this and then let's say you're taking out a canine or like a lateral, something like that. And then you take it like when you pull the tooth out, you have a big piece of that buccal bone just fused to that lateral surface of that tooth. And
Yeah.
then you see that tissue is just totally unsupported at that point, and that's something we want to avoid. Have you found any good ways to avoid that from happening?
I mean, yeah, I think I'm sure there are situations where it's truly ankylosed bone, whatever, 60-year-old patient, 7-year-old patient with a number 6 or 11. But most I feel like are not. And so with care, you could get it out. And so, yeah, for me, it's kind of elevating carefully, not don't want to pinch pressure, especially like between lateral and canine, right? Because
Mhm.
if you're elevating there, the weaker tooth will give, which is clearly the lateral. So just
Mhm.
being conscious about that. But then I put the ash on and I do more of a twisting movement gently, right? Forward or clockwise, counterclockwise, back and forth, twisting. very carefully. You could do the universal. I just find the ash is a little more grippy for twisting. What you don't want to do is the ash, going straight buccal with lateral forces because it's such a powerful lever. That's when I feel like I've seen residents and others just bust the whole buccal plate off. So if I'm twisting, and it's just like, it's like the tooth is in cement type feeling or concrete, that's when I'm backing off and I'm thinking, okay, now we need to do a little bit of space creation. And usually I try to do that with an osteotome. Lately it's been the spade osteotome, tapping in with a mallet. I'm sure you have some ideas and conversations about that. I think a lot of
Mhm.
surgeons are hesitant to use a mallet and like an osteotome that's meant to be malleted, especially if it's a local patient. But I've found if you prep the patient, you kind of explain what's going on. You say, hey, who's going to feel like this is why we're doing this. Most are understanding and think if you don't explain anything, you just start tapping away. Of course, it's going to be kind of an abrasive experience. If you're like, what the heck's going on? They're freaked out.
Yeah, exactly.
How about you? What are your thoughts?
Yeah, one thing in addition to those, I was always taught as a resident, especially for anteriors, maybe like canine forward, is if you can put your index finger on that buccal aspect of that tooth, and
Mm,
then even sometimes put your thumb on the palatal, it really gives you that tactile sensation as you're luxing that tooth and twisting it. You can feel if it starts to break or if something starts to crack in the bone, and then you
yeah.
can stop, and then kind of do some of the other techniques. Many times, like I said, you do that gentle twisting, side to side, give it a second to expand that bone, and you can feel that the buccal plate's totally fine. It just comes right out. But when you do start feeling those, either cracks or kind of you can feel that like expansion of the bone, and it maybe feels like it's starting to separate a little bit. That's when you want to stop and take those steps to prevent that buccal plate from coming out. So that's one thing I've done. Now, talking like you mentioned about the osteotomes, a lot of times I'll prepare my patients before we do an immediate implant and talk to them about what I'm looking for. You show them on the X-ray, this bone's very thin, but once we get the tooth out, if there's enough bone to grab onto that implant, we can place it. And so I think when I've prepped my patients with this kind of discussion, and then I need to use the osteotome, I let them know, hey, this you're gonna feel some tapping, feel a little bit intense here, but this is how we can preserve as much bone as possible for that implant. And when you kind of prep them and then you explain why you're doing that, they're just like, okay, yeah, whatever it takes. I mean, I would love it if this works. And then when I'm using those osteotomes, so I've actually posted on the forum if anyone's interested, a couple pictures of the ones that I've recently been using because I tried a couple of them. Some of them are really like a little too thin. They kind of bend if you twist them at all. Some of them are just really fat and then they don't do their job like really getting in between that PDL and the root and the bone. So I posted a couple pictures there for people who are interested. But what I kind of try to go towards either the the buccal or the sorry, not the buccal, the mesial or the distal, staying away from that like buccal, because that's where if you're malleting anything near that buccal, you can totally crack that plate. So I think that's one of the key like underlying principles when it comes to these atraumatic extractions is you want to try to focus a lot of your efforts on the kind of mesial, maybe mesial slight buccal and distal slight buccal, and be very, very gentle on the true buccal surface of that tooth. Whether it's drilling, whether it's splitting the tooth, or using like a spade. Having that mental picture of where you're going to be placing that, because those areas of bone are just a lot stronger and you're less likely to break off a piece. You know what I mean?
I would say in conjunction with that, so I'll like because I'll use like spade osteotome that seems to be the best one for me. Tapping, mesial, distal, forceps back on there, trying to twist. If I do that a couple times and it's like there's literally no PDL and there's no space, then that's when I kind of start rotating back and forth. So then I'll go to like a thin burr, remove a little bit of buccal bone, sometimes maybe with like a 701 or 702, a little bit, maybe a millimeter or two. And then you tap again and you're twisting, trying to see, because sometimes just, there's so much bone on that coronal portion that no amount of tapping and stuff is going to get it. So you kind of sometimes have to remove a little bit of bone, re-tap. It's like a slower give and take process. But other times, yeah, you tap right there, you create the space, and boom, that tooth is coming on out.
Yeah, I found that like when that first step is not working, I usually just go to a thin burr And like you said, I'll do a very, very skinny trough on that mesial buccal and distal buccal, just right on the if you kind of envision the shape of the tooth, you're just trying to stay more mesial and distal rather than buccal. And it makes enough of a space that if you osteotome again, you can do a little twisting if you have the right osteotome. Many times at that point, the tooth will come right out, and that buccal bone is still just as high as it was to begin with. Now, I will say you got to be mindful, especially if you're doing like a real minimum flap. Sometimes in residency, we get either taught or we get used to using like a ronger or an instrument and grabbing a little bit onto that buccal bone and maybe even a little bit of that palatal bone to get more purchase on a tooth that's broken, which works, right? But if you're going out of your way to do an atraumatic extraction, you want to try to avoid doing that if you can, right? 'Cause you're just automatically going to be sacrificing some bone. And so that's one thing I'll just say is when you can't see it because your flap's small, just be conscientious of that. My next step is like if you can't, let's say that tooth is fractured off very commonly with those root canal teeth, or for whatever reason the tooth breaks, maybe big cavities, and you can't grab it. Um, don't hesitate to section. I guess early on when I was learning to take out teeth, it seemed very odd to me to section like a single rooted tooth or maybe like a premolar. In my mind, it was just like, okay, just remove more bone so you can grab it better. I was thinking, okay, you want to section like a wisdom tooth, you want to section like a lower molar, but like a canine. It just didn't seem right to me. I mean, maybe if it's super weird angulation, cut off the crown and kind of get it out. But I will say, using a thin burr to section really any tooth that's snapped off below the gingiva and making that space can make a huge difference in getting that thing out, atraumatically.
Oh, yeah, for sure. I mean, I think that, like, for example, the other day I was referred to extract tooth number 23, I think it was. Anyone who's taken out like a 20, tooth number 23, 24, 25 on someone who's like relatively young, 20 or 30-year-old, 40-year-old, with like severe crowding, right? These teeth are so crammed together, there's no room for a
Yeah.
forceps to grab onto the tooth. It knows that usually the best way to get the tooth out is to section it, like, because you just don't have anything to grab onto,
Hmm.
without totally traumatizing teeth next door. And so, like, if you've done a few of those, you start realizing that if you're careful, you can, even these really thin, narrow, single rooted teeth, you can section pretty fairly quickly and carefully. And if you flip out, then you take the crown off and you section, maybe you take off like I don't know, the lingual wedge or a mesial wedge. And now you can kind of get your elevator in there, and there's space now for that root to kind of move and get out of the position. Those are some of the hardest teeth to take out, honestly. The tooth that cannot be grasped with an instrument. It's so
Yeah.
difficult. You have to be
Oh
so
yeah,
careful.
absolutely. Now, when you're sectioning a tooth like that, do you have a preference on whether you make your actual, burr cut mesial to distal or buccal to lingual, or is it just completely dependent on the tooth in the situation?
I would say, yeah, majority of the time I'm going from buccal to lingual on the cut, which means I put my elevator in there and then I try to take the mesial half off. And so like I'm elevating mesially or distally,
Hmm.
mostly because of that. Because it's like if you went a mesial distal trough and then you put it in there, I feel like if you start elevating with thin bone on the buccal, you're probably gonna crack the plate off, is my thought.
Yeah, yeah. I've done both, and I feel like my standard approach is what you were saying. I found sometimes, if the root is pretty like narrow mesial distally, like maybe some single rooted narrow premolar, if I section it from lingual or palatal to buccal, you just got to be super careful that you don't, nick or injure that buccal bone when you're doing it. Sometimes what I found is if you go mesio to distal, and then you pop out the whatever tooth is more palatal or lingual, whatever root portion is, then you can really carefully use the spade, and it now that tooth, the buccal piece wants to just go out like away from the buccal plate, if that makes sense.
Yeah.
So I mean, I've definitely done that, and it's been pretty successful. But yeah, I don't know. I think it's kind of just a personal preference. I've definitely heard some people say they always go mesial distal, which was kind of a surprise to me, but they just want to avoid injuring that buccal at all costs. You know what I mean? But you're right. If you do that, you have to be careful not to just stick an elevator in there and twist, because that's going to put a ton of pressure right on that buccal plate. You know what I mean?
Yeah, I feel like if you're gonna do that, for sure, like I would put a thumb or my opposing hand on the buckle, anything to reinforce the buckle before you start elevating. You just kind of want to support it, little tips like that. Next question is so let's say you've got this tooth out atraumatically, when do you decide, yeah, this is a good candidate for immediate implant? What are the contraindications, indications in your mind?
Yeah, so part of it is I'm envisioning what the X-ray looked like before, right? So if before we even start, there's the roots are sticking into the sinus, there's like almost no bone, there's a huge periapical relucency, just like surrounding all the roots. They're conical roots, so there's not like any bone in the middle of the socket. Those are all things I'm thinking of. Okay, this is going to be more challenging. Depending on what implant system you have and what size implants, you may need to defer. So when I have the tooth out, I do the standard curette, clean it out, really visualize the socket. I like to get a curette and just very gently put the curette in the socket. And because I haven't opened my flap up super wide, I'm just using tactile to feel exactly where that buccal bone ends. If I'm putting that curette in that socket on the buccal and gently sliding up and boom, it starts sticking kind of towards the gingiva, like, you know, 6 millimeters, 7 millimeters subcrustal, then that's, not ideal, right? But many times, if you've done these techniques, you can feel the buccal bones just a millimeter under the gingiva, and it's nice, tall, and strong. So then you have to decide with the amount of space you have, mesiodistally, can you get an implant in there with whatever system you have that's going to have retention, right? And so honestly, like, I think the more of them you do, the more you realize that with the proper techniques and proper implants, many, many, many sites can receive immediate implants. I've spoken with surgeons who essentially plan on being able to do an immediate implant for every single extraction, obviously besides third molars. So I think with that mentality, you have to really start asking yourself, like, what are the things that are gonna inhibit me from doing this, and why? So I think if you've used the proper extraction techniques, many, many sites can be good candidates. Now, something I forgot to mention is like when we're taking out teeth to do immediates, if I've discussed it with the patient, something I want to do, I definitely try to avoid certain instruments. I don't use like a crier. I love the East West, um, but like I'm not going to use the East West to take out that septal bone to get one of those roots out. You know what I mean? And so as soon as I have like let's say a lower, like a number 30, I'll look at that septum. And for me, it's how wide is that septum and how much room do I have to the nerve and how much buccal bone do I have. If those three things line up, then I'll attempt doing immediate.
Nice. Okay. I mean, does anything with like the soft tissue type or anything like that determine if you're going to do an immediate or not?
Yeah, I mean, if the patient had like a parulus with, very irritated soft tissue, maybe there's like a perforation from the root and the tissue is just very, very poor quality, that's definitely something you want to take into account whether that's worth the risk. I have placed immediate implants on patients who had, straight up paruluses and they have completely healed in, but you have to make sure you got your way to clean those out very, very well. Basically patch up that soft tissue, usually with membrane on the inside, graft that area. So there are additional steps you have to take. And if you're not doing those things, or if it's questionable, then it's probably going to be better to just graft and come back.
Okay. Is there any stages while, let's say, you decide, okay, I think they're a good candidate for the implant, and you start going through the process of drilling pilot hole and everything. Any steps in there that would cause you to say, let's abort and not do it?
Yeah, it's rare, but I've had, one or two cases where we were drilling in the septum of like a number 3, and it had pretty good bone, but just the pressure of the drill slowly, expanding that septum has pushed the buccal bone out laterally and kind of cracked it and like loosened it up to the extent where it's like, okay, now wedging an implant in there is not going to be the best situation. It almost is like a little bit of a ridge split. You actually get a little more space, and when we grafted it, it had plenty of bone later. But in that situation where it's going to be questionable having implant stability, that's where I would kind of defer.
Got it. Yeah. Excellent. Well, that's definitely helpful, I think, to hear. Any other preoperative planning pearls, maybe things you're taking into consideration before even taking out the tooth?
Yeah, there was a podcast recently that talked a little bit about the tunnel grafts, and one of my good friends, Dexter, he does these all the time. If you know you have a very, very thin buccal bone on, like, let's say a central maxillary central incisor, that could be something that you plan on doing, before you do your implant, and so you don't elevate that flap. You really want to be minimal, and then you would, I don't, not to go into all the details here, but basically you do plan on doing a tunnel graft to basically bulk up that very thin buccal bone. So I think that's one thing. And then I think there's also just scenarios where, it's just not a great idea. Maybe the sinus is severely pneumatized. You have very, very, very little bone. Maybe the patient, you have to look at the patient factors as well. Maybe they smoke pack a day, 2 packs a day, diabetes, you know, patients who are on, Zometa, Xgeva, other things like that. You have to take all those things into account. I'd be interested in hearing people's experiences. Maybe they can post in the forum or reply, but what are your thoughts on doing immediate implants for patients who are a little bit higher risk versus two staging them? Because I've heard some people's thoughts are, hey, you're already doing surgery. You're already, irritating the area. You're already making a flap. Placing an immediate implant at that time is actually less risk than doing this 2 times. You know what I mean? So I'd be curious to know kind of what people are doing. I've definitely done both ways, immediates on those kind of patients that have worked great, and also just waited and sometimes decided not to do them. So,
Yeah.
I don't know. What are your thoughts on that?
Yeah, I mean, I think especially, I think just another probably motivator is if it's, maybe poor healing quality, but also if they're very anxious and they like are saying they have to be sedated for every procedure. That's just one more thing to think. Okay, if I could get an implant in here, I would do it immediate as opposed to knowing we'd have to resedate them and just taking all that into account. Like
Mhm.
what does this look like and what are the risks to doing this twice versus once? The things to maybe delay would be, um, a prior failed implant. I think if they do have really poor bone quality, poor healing, maybe there's a thought there that, well, maybe we want to let them heal and then come back to like a fully healed site as opposed to putting an implant where potentially there's newly grafted bone that could be inflammatory. There's so many ways of thinking about this, and I'm sure many different opinions, and people have very dogmatic, strong opinions about stuff like this.
Right. Some people will say if you have to pack a socket full of, dead bone, you're requiring much more of the body to heal versus 90% of that space is occupied by titanium, and now there's a very small amount of bone to heal to fuse to it.
Right.
That's one theory. Another interesting thing that I've seen coming up more, and we can have a whole nother discussion on this one, is the depth of the implant, how that influences the soft tissue thickness, like is discussed in the Zero Bone Loss Concepts book, how you place your healing abutment. I feel like a lot of those things are actually pretty advantageous with immediate implants because you tend to place them just a tad deeper, a little bit taller healing abutments. Kind of get what I've noticed is you get pretty good, robust, thick, coronal tissue. So I mean, there's just so many different things to think about. There's also some studies I recently read that talk about if you're specifically doing an immediate implant that torques between 10 and 15, we're talking just enough torque so that thing isn't moving, have high success rates. So there's a lot of interesting research out there, and I think as time goes on, we'll probably see a trend towards doing more of these. At least that's been my experience so far.
One other thing, I'm a big believer in the patient's mindset. So occasionally I'll have a patient sit down and like they say, I do not want an immediate implant. Like I heard so and so did this and their whole life is ruined. If someone's saying stuff like this and or they're very like, are you sure, doc, we should do an immediate or things like that, I'll say, hey, let's delay because if their mindset is already against one of the options, I think that in itself could potentially influence the healing ability. I think it's good a factor if they go, oh, I really want an implant. I've heard they succeed. And like that, I think it helps the body to heal better. So there's probably not a lot of proven research on this one, but it's like my anecdotal experience.
No, I mean, there's definitely some truth to that because I mean, if someone has that mentality and then anything goes wrong, they already have set themselves up to be ready to jump on that. You know what I mean? And
Yeah.
so I think that's definitely reasonable.
How about armamentarium? Any instruments that you want to mention that you've come across that are really helpful for doing this procedure, this process?
Yeah, so I mean, I'm sure everyone has got different setups. Where we're at, we're using primarily Nobel, Nobel Active, those kind of things. So for our setup, what I found really useful is for maxillary teeth, definitely the VersaBurs. Highly recommend those. You do have to be a bit more judicious when you're using those for immediates because they can definitely put a lot of that lateral pressure, like I was talking about earlier. And if that bone's not strong, it can potentially kind of crack it or break it on the buccal. So maybe running those forward versus reverse. But being able to use the VersaBurs, using osteotomes for sinus lifts, done plenty of sinus lifts at the same time as immediate implants, and they do great. So, being ready to do that, we've used a lot of PRF. We make PRF membranes to help thicken up the bone. One thing and we can do a separate topic. There's a surgeon I want to talk a little bit about this, but there are a lot of people who will use like a collagen graft, like a muca graft on the buccal, right under that buccal flap to kind of try to thicken that up. In the case of that being thin, there's so many different techniques that can be used, and I think that's one of the difficult things about doing implants, especially immediates, is there's 100 different ways to do it, if not more, with 100 different techniques and materials and implants and systems. Every implant's different. The connection's different. The healing abutment's different. There's, just so many companies who make so many products you can use in many different ways. So I think really learning what sites need what treatments and when is, it takes a long time. And when you can get that down, I think that's when we start seeing those surgeons who are placing immediates in almost every site and having success.
Yeah, for sure. Yeah, and I think it's I mean, having an open mind, trying different instruments, talking to people about what they use, I think can only help you to evolve to use the best instruments. I love so the VersaBurs for those who aren't familiar with those, maybe you're in a different country and different things. They're the osteodensification burrs. They're basically shaped with a how would you call it like a tip that is wider and broader and kind of meant with this parabolic, but it's a shape to the burr that you run in reverse and it pushes bone. Instead of cutting it and pulling the bone out, it's pushing the bone laterally back into the socket. And so certainly like a posterior maxillary soft bone. Like I usually will go in with like a precision drill or a 2.0 or a 1.5 twist just to start it. And if that is just like Swiss cheese, a super soft bone, I go straight to the Versa, start spinning those backward. And if you do in the right order, not like doing huge jumps in size, rarely will you cause a fracture of a bone. They're
Hmm.
excellent to lift up membranes, a couple millimeters. Just very versatile, helpful burrs when you have super porous type 4 bone. Any other comments on that stuff?
Yeah, I mean, there's so many ways to use those things. They're incredible. I know people who will use them during the sinus lift process. Get them just to that right depth. Maybe osteotome once or twice, two different sizes. Start placing bone versus burr very gently to kind of condense that bone in there. I mean, there's a lot of different ways to do it, but totally agree that if you haven't used them, I definitely recommend it. You can get, I mean, torquing implants to their upper limit in maxillary bone that felt pretty questionable to begin, so definitely a helpful tool.
I found too, just a side note, this is more on the probably a podcast for sinus lifts, but let's say you're kind of between, like a not wanting to do a lateral versus a vertical or internal versus external, however you say it. Let's say you got like 6 millimeters. If I use like the first VersaBurs and I kind of push that bone up a couple millimeters, I'm like stopping short, pushing it up. maybe drilling to 5 instead of right at 6, and then I'll like maybe get to my, let's say, 3-2 drill, or like 3-8. Then I'll switch over and go to my like internal osteotomes and tap up the rest of the way, and I can pop the sinus flora another couple millimeters. So there's just things you can do like in combo with osteotomes. I feel like to get to lift that sinus floor several millimeters. I mean, maybe not like 5 plus, but you could easily get 3 or 4 millimeters doing internal with the vertebra
Hmm.
and potentially an osteotome.
Yeah, absolutely. And going a little bit back to just, immediate implants in general, taking out, atraumatic extractions. I think one thing that's been helpful for me, and I made another post just on this topic, is have like a mental list of requirements. Like what are things you're looking for? And, in terms of, let's say you want a gap between the buccal bones so you can graft it. Let's say you want the implant to be a millimeter below the buccal plate. Let's say you want the implant to be 2 millimeters from any adjacent root. You start putting together a list of things. You want the torque to be at least 30, let's say. Whatever, it's different for everyone and for every system, but come up with a list of some of these things so that way when you run into a situation where things are not working out the way you want, for me, it's made it a little bit easier to then say, look, these are the things that I really am aiming for to have excellence. Multiple of these things are not lining up. Maybe it's time to take this implant out and graft it, or change my approach on extracting this tooth, or whatever it is. So that's been something that's been helpful for me because the more complex the surgeries become, you can get kind of tunnel vision, and then you maybe you don't want to be one of those people who ends up with those implants that's like they're presenting at a conference and everyone's like, "Ooh, how did that happen?" It's like he probably got tunnel vision and he was focusing on 50 different things at once, which makes sense, but taking a step back and really knowing what your parameters are and what you're willing to compromise and not, and then just slowly building on that technique over time.
Yeah. I would add to that, and this is more basic stuff, but like if you're going to be doing immediate implants and use a lot of implants, one, you want to have like every size and multiple styles of implant sizes. I feel like if people can have small amounts of implants, it's just more likely to make a bad decision because you're like trying to do things with what you've got, and what you got maybe isn't the right thing. So have a ton of implants, and then two, have a low threshold, for boarding or taking out the implant. I don't think it's not the end of the world. Let's say you place the implant, you graft around, you suture it, and then you take an X-ray and it doesn't look good, or it's too close, or something is whack, and you're like, oh shoot, I didn't realize I was whatever in this direction, that direction. Just take it out and graft it. Like, trust me, it's
Hmm.
gonna save you so much headache to take care of it right then, and explain to the patient. Every patient I've known will always be so grateful if you explain that. Hey, I was about to do the implant. We put it in. The bone was whatever. It wasn't torquing strong enough. We really want primary stability. You just explain that to any patient. Thank you. Yeah, clearly this guy wants to do what's best for me. Much
Hmm.
better to do that and have a low threshold to kind of take it out and graft or whatever it is than just okay, let's just try it, and then
Cross your fingers.
yeah, and you're having to take out an implant later. Anyhow, just like you're saying, and I think we mentioned this last podcast, but have those parameters. Probably have a good assistant that isn't afraid to talk to you, to know those parameters, because you want someone else looking and saying, being brave enough to say, "Hey, is that this looks funky," or "Are you worried about that?" or this or that. Sometimes that can help you. So just those small things.
Yeah, absolutely. And again, I can't encourage people enough to hop on and share their experiences because there really are so many different ways to do this. And I feel like as a community of surgeons, we just have so much to learn from each other. Different techniques, different instruments, different ways of going about things. And at the end of the day, if we can all kind of learn from each other, it just benefits the patients.
Yeah, awesome. Well, I think this has been a great topic. I mean, I think certainly we haven't exhausted everything. There's books been written about this. So we're just kind of getting into some of the initial things about it. So great topic. Always helps. Like we're talking about, shoot an email, a text, jump on the website, anything to give feedback just is so helpful for all of us. So thank you so much. One last question. You reading any good books these days?
Yes. So, I'm trying to remember. I just started it. It was a recommendation from my program director. What's it called? Oh, it's Unreasonable Hospitality. That's what it is. So it was actually I was talking to Dr. Keith Schneider. He's a surgeon out in Cleveland. Awesome mentor, trained me during residency, and he was always giving me recommendations. So the two that he recently told me about was one was Eat the Frog, which I had never heard about. And it's kind of funny to be honest, but it's a good book. It talks a lot about, what are the quote unquote frogs, in your life? Because it's like what the idea is, if you had to eat a frog, are you going to do it at the end of the day, when you're tired and you want to go to sleep, or are you just going to wake up in the morning and hammer it, right? Eat it, over with. Worst part of your day is over. It's like, the meme. I don't know if you've ever seen that meme where it's like the best part about doing a run in the first thing in the morning is you ensure your day can't get any worse. It's that idea of like figuring out what is the most important thing to do and then doing it first. So many of us have the tendency of having like a list of like 10 things to do and doing like the 8 easiest ones just so we can check them off. And then it's like so much inefficiency. We're not really making progress on the things that are going to make the most difference in our life, in our work, in our learning. It talks about the 80/20 rule, like something to the effect of like 20% of the things that we need to do will have 80% of the impact. But so many times we just avoid those. So that the book goes into a lot more detail about all that stuff, which I think it's just awesome. Like I love opening your paradigm, opening your mentality to just different ways of doing things because they just once you start doing them, it's just like, wow, that makes a lot of sense. And then the second one is Unreasonable Hospitality. I think, have you read that one?
Yeah.
Yeah. I mean, I just started it, but so far it's been incredible.
Yeah, I love one of the concepts of that book, um, which was to, so it's a guy who he's in the restaurant industry and he takes a restaurant to like, I think number one, if I remember correctly, in the country or the world, which is extremely hard to do. But one of his core concepts to do that was treating the staff like they were gold, basically, more so even than the clients. So like they did everything to create an incredible work environment for their team members. Because the thought was, if our team members are all super happy, they're engaged, they're passionate about what we're doing, and they're loving the work, that will inevitably make the clients, in that case, the people eating the food, um, enjoy things more and their experience will be better. Whereas if you go reverse and you say, let's do the clients first, like I know I've seen dental offices do this where there's like a manager or a surgeon or a doctor who says, the patient is always number one. And if anyone makes the patient upset, basically you're all in trouble. And they start yelling at the staff and the assistants, and you guys can't believe this. We got a bad review. And that, unfortunately, it works the opposite. When you do that and you don't stand up for assistants or staff members, let's say a patient is kind of berating them or rude, because if that's your motto, oh, the patient is number one, you would never stand up for a staff member over a patient. Anyhow, that book basically taught me that if you want the patient experience to be the most incredible it can be, you have to have your team members have a great work environment, and you have to have their back, especially when patients are being rude, disrespectful, stuff like that.
Yeah. No, there's a lot of pearls in there. And it directly applies to medicine and dentistry, surgery. I mean, obviously it's focused on the restaurant industry, but there are so many things that even just partway through the book that we can definitely apply. And I think if we did that like as a whole in dentistry, it would make a huge difference on how the public perceived us and just their experience in general. I mean, everyone knows that you know, dentists are almost like unanimously hated. No one wants to come see us, and there are reasons for that. But um, I highly recommend that book.
Yep, it's an awesome one. Very cool. Well, thank you for sharing those books. Thank you for sharing your pearls. It's been a great topic. And everyone log into that website and give us some good comments on the forums.
Yes, absolutely.
All right, Jake, always awesome spending time with you, my man.
Yep. Thanks. Have a great night.
Good day. Bye. Thank you so much for listening to this episode of Everyday Oral Surgery. For more information on these podcasts, please visit everydayoralsurgery.com. I love feedback and would be very grateful if you would reach out to me via my email, grantstucki@gmail.com, and let me know what you thought of this episode. Or you can text me at 720-441-6059. Additionally, if you have any topics you'd like to hear about, or if you would like to be a guest on the podcast, please email or text me. I found many of my interviewees through people who have been contacting me and have been listening, and I've gotten so many great ideas for more podcasts, and that's what helps keep the podcast rolling. So I really appreciate you making that extra effort and helping me out with feedback and knowing what to do next on the podcast. Thank you so much.